Hello, everybody. Welcome to Nova Southeastern University's South Florida Geriatrics Workforce Enhancement Podcast, also known as SF-GWEP Podcast. We're here to educate, encourage, enhance our knowledge and skills, and promote all those amazing health professions experts working with the elderly, including caregivers and interprofessional teams. My name is Naushira Pandya, and I'm professor and chair of the Department of Geriatrics at Kiran C. Patel College of Osteopathic Medicine at Nova Southeastern University, as well as project director for the South Florida Geriatrics Workforce Enhancement Program. I'm really pleased to introduce our guest for this podcast. Dr. Heather Barnhart is Director of Clinical Affairs for Koya Medical. Previously, she was professor in the Physical Therapy Department at Nova Southeastern University in Fort Lauderdale, Florida. As a physical therapist, her expertise resides in integumentary dysfunction, where she holds 4 board certifications and credentials. Heather has diverse work experience in academia and in the private sector. She's a key opinion leader and is actively involved in numerous professional organizations, conducts research, publishes, presents and teaches nationally and internationally on integumentary-related issues. She's past president of the American Board of Wound Management and is past board and executive committee member of the Association for the Advancement of Wound Care. She is currently on the board of the World Alliance of Wound and Lymphedema Care, advisory board for the Why Wound Care campaign, and editorial board for Today's Wound Care Clinic. Dr. Barnhart, I'm so pleased to welcome you to our podcast.
Well, thank you very much for having me here today.
We've worked with each other off and on for many years, but it's amazing that I really don't know the full extent of your involvement in skin problems and pressure sores, pressure injury as it's called these days. So we're excited to have you here today to talk a bit more about it.
Thank you.
Can you start by telling us why this topic is so important to you?
Absolutely. It's important to me for several reasons. For one, there is a lot of misinformation out there about pressure injuries, such that they're all due to negligent care. That's not the main reason why they happen, although that can happen. So proper education and awareness is really important. Secondly, pressure injuries affect people of all ages for a variety of reasons, and they can have a really significant impact on a person's quality of life, not to mention the financial implications. And third, but not last, though most pressure injuries are preventable, some are not. And I think that's really an important consideration for people to remember. So when a pressure injury is present, it's important to know the right way to manage these wounds to reduce the pain, maximize the outcomes, and reduce costs and complications associated with these injuries.
Yes, it's a huge problem. And in my experience over the years taking care of patients and talking to families, I don't think they realize that when a pressure sore develops, how serious it can be and how long the trajectory can be towards healing.
That's absolutely right. And a lot of that has to do with the extent of the injury itself. And we'll talk about ways that we classify these wounds and what that means, but it is why the awareness and the education about these is so important, to demystify them, but also to let people know that they're not all due to bad care or negligent care. You know, we see the signs on the freeways, and we see the advertisements
Indeed.
About all the litigation out there, like poor nursing home care, and that's really not the case. Again, there's situations that can happen, but most of the time these develop just as a process of aging, but also sometimes due to some of the risk factors patients present with.
So as a clinician, what I'm interested in is what should our health professional colleagues know? What are the basics that they should know about pressure sores in terms of, obviously you mentioned some risk factors, and then how to recognize them, how to intervene promptly?
Absolutely. I think there's 4 key areas. One is really the awareness, which I'll go into in a moment. The other is really understanding risk assessment and prevention strategies and really implementing those and staying on top of that, as well as the importance of adequate, thorough, objective, and descriptive documentation, because if it's not documented, it didn't happen. And lastly, we have to also think about the way these types of injuries present on different skin color considerations.
Very important.
Very important. So patients with darker complexions have a greater risk for developing these only because we don't see them as readily. So that's an important consideration as well. But pressure injuries of the skin and soft tissues can affect up to almost 3 million people here in the United States. So it's a pretty significant.
It's a large number.
It is. It's a significant problem here, but worldwide as well. It's not just a U.S. issue.
Can
right?
I stop you there for
Yeah.
a second? So 3 million people is a lot.
Mhm.
Do we have an understanding of how many of those might be in the hospital setting or in the institutional setting?
Yeah, great question. So again, pressure injuries don't discriminate. They present everywhere across all different clinical settings. So the numbers kind of indicate that in the acute care facilities, the hospitals, the incidence can be as high as 15%. In long-term care and nursing homes, skilled nursing facilities, it can be as high as 30 to 40%. Now, that does not mean that the care in those facilities is worse or they're not paying attention to that. It's just these are where patients live, essentially. And so they're also older, have a lot more comorbidities, complications.
Yes.
So the likelihood of their skin having complications is a lot higher. Those numbers shouldn't reflect the type of care that they're receiving. It's just they're in an environment where they're living, and a lot of these injuries are just part of the natural aging process.
Yes, and now we see, obviously, in nursing home settings, far sicker patients who have
Absolutely.
multiple comorbidities. Hospital stays are shorter. And I think what we're struggling with in our patients is the staff turnover, the shortage of staff. And so we're having to train
Absolutely.
new, staff members all the time.
And that's a big challenge. And a lot of people like dealing with skin issues, right? Sometimes they're not pleasant to look at. They don't smell very good.
No.
But we have to remember, we are really the healthcare providers, regardless of your background. We are the skin stewards of our residents, of our patients. And
That's such a great term.
yeah, well, I think it's just important to remember, I like to talk about skin as being our body's suit of armor, which is very
Which it is.
protective. It is, except sometimes we get a chink in our armor, right? And that becomes a vulnerability. And that can lead to a whole host of problems. So we really need to make sure that suit of armor remains as strong and intact as possible so we can mitigate some of the risks. And that's an important thing you touched on. Risk factors for developing pressure injuries in general include any form of immobility, reduced perfusion, meaning if there's a reduced ability of the blood to flow to certain body parts, malnutrition is a huge component, and sensory loss. So, and again, other patients at risk for pressure injuries are anybody with, cerebral vascular conditions, cardiovascular disease, if they've had a recent fracture, diabetes, incontinence. So there's lots of different factors that can contribute to a patient's vulnerability for developing such an issue. And a lot of those patients are the ones in long-term care and in nursing homes and skilled nursing. So it's a greater risk in those environments.
As an endocrinologist also, I'm very interested in why people with diabetes are at greater risk. We did some work about skin water content in people with diabetes, and there seems to be a difference. What is your experience about that?
Well, diabetes, as you know, is a very multifactorial, multi-system problem, essentially, right? And with respect to the skin, I think for the patients in general, when they lose a lot of that protective sensation or the neuropathy that can develop over time, it really puts their skin at risk for breakdown. We
Yes.
only need to be able to detect 10 grams of force to know we're potentially harming our skin. And when we lose that ability, which is not much, when we lose
Not
that
much.
ability, people are at risk and they don't realize it. And so diabetes also changes the skin, and we call it really like a trineuropathy because it involves the autonomic system, it involves the motor system, it involves the sensory system. So it really sets people up for greater risk. And, people always talk about, well, this patient population's not overly adherent or compliant, but I push back and say, that's really not a fair state. How easy is it to remember to check something when you don't feel it? There's kind of a disconnection. When you lose sensation in your feet, for example, you kind of have a disconnect with your feet. They're there.
That's it.
But if you don't feel it, you don't
Yeah.
think about it.
I have a story about that, actually. I saw a patient last week who I haven't seen for a long time. And he's a very bright man, has diabetes, but for various reasons he couldn't see me in the clinic. And he has a 4-foot amputation and a, custom molded shoe, and it's a fair amount of protection. He's totally aware of the risks and looks at his feet every day. But he came in with a horrible callus in some boggy areas on the stump. And we know that underlying that is probably an ulcer. And that happened just in one weekend?
Yeah.
I said, what happened? He said he was walking at the Renaissance Festival.
That's all it takes.
For a long time. And I was astonished that that's what it took. And he had his proper shoes, padding, everything.
Yeah, and even in the most adherent, dedicated patients, things can happen. And it doesn't take that much time, right? He was wearing the right shoe wear. He was very aware. He's mitigating all his risk factors. He's probably managing his diabetes very well. But when you have that loss of sensation, minor little trauma, minor little rubs, walking excessively, especially in patients with diabetes, because a lot of times they have biomechanical changes to their feet, so their pressure points are not where they're normally supposed to be, so they're more susceptible. And the hard part, when patients start losing body parts due to diabetes, a toe or a forefoot or a leg or whatever the case may be, the 5-year mortality rate is significant.
Yes.
It's like 50%. And so I like to say, and other colleagues of mine like to say, that amputation is a failure of treatment.
It is in this day and age, if people have access to
Correct.
healthcare. I think we have to qualify that.
Absolutely, we do, but it's important that that's not our first option.
No.
That we look, what else can we do to try to treat this individual, treat this wound? Let's try to salvage this first before we go right to amputation.
You mentioned the importance of documentation, and I think before that even comes recognition, like what is the skin lesion your nurse is looking at, or what did the nursing assistant pick up? I always feel like the first line caregivers are the ones that have to be trained
100%.
excessively.
100%.
But how do people in the healthcare setting, the caregivers, the healthcare professionals, how could they differentiate pressure injuries from other chronic wounds?
Great question. Typically, pressure injuries are going to occur in areas where there's bony prominences. So like the back of the heels, right, for example, or the sacral area, the occiput, the back of the head. But it's important to remember that pressure injuries can occur anywhere on the body if there's a pressure-causing agent. So if they're laying on a catheter line, if there's a needle cap left in the bed, if there's sheets that are wrinkled, really anything can cause pressure, right? So the first thing to recognize is there a problem with skin integrity? So if you see something, say something, as we always say. And sometimes we don't know right away what is the underlying etiology or cause. But it's always appropriate to start with describing something in the documentation. Is it partial thickness or is it full thickness? Once we have more information about maybe the cause of that wound, let's say we do discern that it is a pressure injury, then what they should do is follow the staging or category system set forth by the National Pressure Injury Advisory Panel. That has been specifically developed to describe pressure injuries, and it involves stages 1 through 4, going from stage 1 where the skin is intact but it's not blanchable. So if you push on it, that tissue refill, that capillary refill doesn't occur. That's a sign that there's tissue damage.
Correct.
Stage 2 would be a partial thickness injury. It looks like an abrasion. Then soon as you get to stage 3, stage 4, we're talking about deep, full thickness pressure injuries. Stage 3 kind of goes into the fat layer, into the hypodermis, but stage 3 can go into bone, muscle, tendon, and deeper.
And that's still a stage 3?
No, that's a stage 4.
Correct.
Sorry if I said that wrong. Yeah, stage 4 is once it passes that hypodermis and gets into deeper tissue structures.
Absolutely.
But we also have unstageable pressure injuries. So if there is too much necrotic tissue or dead tissue, so we can't see how deep that wound goes, that's unstageable. We have deep tissue injury, and we also have medical device-related pressure injuries.
I was going to ask about that.
And mucosal membrane pressure injuries. So there's lots of ways to describe these, tremendous resources to help providers know where and how to document these, but we need to call them for what they are and properly document them as pressure
Because
injuries.
early on in my career, we didn't describe mucosal pressure injuries or medical device-related injuries, but now I'm reading that that's a more accurate description and it's more commonly used.
Correct.
But does That mean it's a different staging of pressure sores, or it's just a different etiology that we're describing?
Great question. It's all an etiology because it was induced by some form of pressure. But what
Yes.
the National Pressure Injury Advisory Panel did several years ago is recognize that a lot of these injuries are caused by medical devices, right? So a
Indeed.
nasal cannula could be a medical device-related
Yes.
pressure injury. Coming out of COVID, all the PPE that even the providers wore, those were pressure injuries, medical device-related pressure injuries, catheter lines, all those types of things. So say, for example, somebody's intubated. If they get a breakdown in their mouth from the intubation, that's a mucosal membrane pressure injury. Mucosa is very different than skin. So we don't stage mucosal membrane pressure injuries, but we should call them mucosal membrane pressure injuries. Typical pressure injuries that occur on the skin should be staged using those different staging systems.
Yeah, I think in this day and age of, high medical litigation, it's so important to trace the trajectory, try to identify the cause as early as possible.
Absolutely.
So in your opinion, are pressure injuries preventable?
Great question. Yes and no, not to be vague. Most are if proper risk mitigation is implemented, which really includes the offloading we talked about, the repositioning, nutritional support, proper medical management. However, there are circumstances when they are not preventable. And we see this at end of life and during what's called skin failure. And I think that's a really important topic for people to recognize. And we need to remember that skin is our largest organ of the body, and just like the heart, the liver, the kidneys, it too can fail. And what's interesting, given that life expectancy is increasing, the risk of skin failure also increases. And skin has a finite lifespan. So there's a point where the body recognizes, I need to preserve heart function, brain function, so it shunts blood away from the skin, and it makes the skin very susceptible to breakdown. And these are really the unpreventable pressure injuries, but it's really skin failure. And you can see this at any lifespan, if there's acute or chronic illness that makes them susceptible to something like this, or multi-system organ failure. But we do typically see this more at end of life in our older population, so they're not all preventable.
And would skin failure look like large or multiple pressure areas that develop very quickly? That's been my experience.
That is correct. Yeah, typically, not always, typically the most common site for skin failure is the sacrum, but it can happen really anywhere on the body, and they do develop very rapidly, very quickly. They kind of start looking a little initially like a deep tissue injury. They quickly can progress to full thickness, stage 3, stage 4s, and they do come on pretty quickly because the body, the skin, if it starts shunting blood from the skin, our skin can only tolerate a hypoperfusion for about 20 minutes. And that's when we start breaking down. That's why it's really important that if somebody's at end of life or multi-system organ failure, we recognize that and really educate everybody involved, because these are not preventable. This is just a visual biomarker of end of life. And we need to educate the patients if they're able, cognitively still present with us, family members, and the medical team.
Yes, I think that would mitigate a lot of distress and blame.
Absolutely. And it's hard. These are visual. And you walk in and you see mom or dad or grandma or grandpa, and they have their skin's breaking down in front of you, and of course they think somebody did something to them, right, if they don't know. But this is why really taking that time to educate and say, here's what's going on clinically in words they can understand. They're at risk for developing some skin issues, some skin lesions. We're doing everything we can to try to mitigate that, prevent that, but sometimes we can't because it's just the body's natural way of shutting down. And so if we take that moment to really set that expectation and let people know it's a possibility, not scare them, but let them know it's a possibility, it does mitigate that reaction that sometimes we encounter.
So important. Thank you for that information.
Absolutely.
What can health professionals do to reduce the risk, and caregivers too,
Sure.
of pressure injury?
Great question. One is identify risk factors for the patients and residents under their care. So things, if somebody is immobile, if somebody is malnourished, incontinent, has alterations in sensation, those are all things to really identify. And even aging individuals, because our skin is different as we age, it's more vulnerable. So using something like a risk assessment tool, like the Braden scale is the most common, And it gives us objective, quantifiable data to show the level of risk. And then
Yes.
based off of that level of risk, there's certain intervention strategies we can
Absolutely.
do. If they do have incontinence, we should address the incontinence, not necessarily just put an adult diaper on them, but let's treat the underlying cause. If it's a mobility factor, that should trigger a referral to physical therapy or occupational therapy. Obviously, malnutrition's huge, so absolutely get your registered dietitians on board, not just from a nutritional standpoint, but from a hydration standpoint. So we need to recognize the risk factors, those that we can mitigate and modify, which are often many, but there's some we cannot. We can't change a
true.
person's sensory status. If we know they have problems with sensation, then we need to address that through offloading, repositioning, using devices that are support surfaces that can support their tissue tolerance to reduce the likelihood. We can't always prevent, but we can reduce the likelihood of them from developing.
So you mentioned something very interesting. I want to go a little bit more into offloading areas that are at risk and also bed surfaces. There's a huge industry around this.
Yes.
And it's difficult for us as clinicians to know, okay, what is the best surface? What's the most economical surface that a patient should lie on? Also, what are the best offloading devices?
Great question. I think it's really important, repositioning first off is going to be critical, especially for patients that are immobile or cognitively impaired, so they don't know how to reposition. So typically, about every 2 hours, if we shift the positioning, document the repositioning. But if somebody is really vulnerable, they might need to be repositioned more frequently, right? With that, we should also utilize different offloading strategies. And what that means is maybe different support surfaces, to your point about different mattresses or bed replacement systems that can offload the patient or the resident. There's a great resource that's part of the National Pressure Injury Advisory Panel called the Support Surface Standards Initiative, the SSSI, and they talk about how to go about selecting the right type of support surface for the individual based off of their clinical presentation. And probably the best way to start is looking to see on your formulary and who you have contracts with at your facility or at the hospital, and start there. And one of your best resources is really to talk to the representatives for those companies, have them come in-service the staff, show them how to use these properly, how to make those decisions, those algorithms to select what type of device might be the most appropriate. And Medicare also has guidelines for that. And so we have different classes of beds or support surfaces. There's a class 1, class 2, class 3. And there's instructions and guidelines on who would qualify for those different levels, and that's really the best place to start.
And
But
they
that's
aren't
why
cheap.
they're not cheap, but that's where the documentation comes in. But it
I
is
see.
cheaper to pay for a support surface than it is to pay for pressure injury.
Indeed.
Yep.
And once they have occurred, you still need to pay attention to support surfaces, right?
Absolutely.
To relieve as much pressure
Absolutely.
or reduce. I'm not sure if pressure can be completely relieved except in certain situations.
It can't be, but we can redistribute it, and that's the goal of what we're
Okay.
trying to do with some of these support surfaces and other devices. And, there's lots of products out there to help relieve pressure or redistribute pressure, but it's important to remember that that's not the end-all be-all. All the other risk factors need to be addressed, and it still doesn't replace repositioning. Even if they're on the best mattress or bed replacement system in the world, they still need to be repositioned. We have to offload those areas. It's gravity. We can't get away from gravity.
That's so important because especially in the era of COVID or people who are in critical care settings, practitioners might think that they're on the right surface, they can stay there in one position as long as they can tolerate it.
Yeah.
And they're not repositioned. What is your opinion about repositioning every 2 hours? I've seen that there isn't much literature to support every 2 hours. There are only a couple of solid papers
There isn't.
in this area.
It's just kind of a starting point, if you will.
We all grew up with
Right.
turn every 2 hours.
Right. And I think that story originated from, that's what it took for the nurses to make their rounds, essentially, is where that came from. But realize everybody's tissue tolerance, which just means their ability to withstand the pressure they're experiencing, is different. So somebody might be able to tolerate a position for 2 hours. whereas somebody else might need to be turned every hour, every 30 minutes. This is why risk assessment is so important, and really understanding clinically the way that individual is presenting so we can match that repositioning to their specific tissue tolerance needs.
That's important. Because I think, you get these standard order sets.
Right.
That are, propagated everywhere, and, people document the turns and so forth, and sometimes you do lose track of this because there isn't adequate documentation.
Right. Documentation is key. And, I'll add one thing. There are times, especially in the ICU, where hemodynamically it's not safe to move that patient. And that is a key opportunity to document, because if you're not able to turn or reposition that individual, because it could essentially lead to their demise because of their hemodynamic instability, we need to document that, because otherwise we should be doing that, right? But if there's reasons, medical reasons why we can't reposition somebody, we need to document that, because if a pressure injury were to arise because of that situation, that's not the fault of the healthcare providers or the facility.
Not at all.
It's their medical condition. And I think that's the key to remember with these as well, is that these are not all caused from poor care or negligent care. There are many of these wounds that happen that are unpreventable, especially as we get towards our end of life.
So what would you advise a busy clinician who is making rounds on their patients in the hospital, be it a nurse leader or a physician, nurse practitioner? What should the quick checkpoints be when they make rounds?
Great question. Well, I think we have the advantage in that the skin, being the largest organ of the body, is something we can see.
Visible.
It's visible, it's something we can touch, and it's something we can interact with. So even a quick skin assessment is important, but that doesn't mean just the skin you see when you walk into that patient's room or the resident's room, right? So it does involve, if you can, turning them so you can see the sides, see the backside, all of those areas. And it's really something as simple as, if you see something, say something. If you know normally how that person presents, then you can kind of readily pick up if there's a change. Is there a reddened area? If they're a darker complected individual, is there a change in their skin pigmentation? Is it a darkening, what we call dyschromia? Are there tissue temperature changes? Are there tissue consistency changes? So visually assessing them, as well as palpating that skin, can pick up things very, very quickly. And the earlier we pick something up and intervene, the better off that individual is going to be.
It's so important because I think many practitioners are not familiar with these subtle changes in darker complected individuals.
That's right.
That's really important. The other areas that I've seen pressure injuries in very frail patients, I think you mentioned, are the occiput.
Yes.
And the scapula, and
Yes.
sometimes even the backs of the ears, depending on how they were lying. And I think clinicians might not appreciate those as potential pressure areas.
Absolutely. And in the frail individual, and it doesn't matter if that individual is really, really thin and cachectic or obese, aging changes the skin, and it makes it much more vulnerable to things like pressure, friction, shear, negative consequences of malnutrition, dehydration, so they are much more susceptible. Even the thoracic spine, if somebody's a little kyphotic, right? Or if they're laying in bed sideline between the knees.
Yeah, the thoracic spine can be a very bony area.
Exactly. And so, we shouldn't see changes there, ideally. So if it's a lighter complected individual, you might see signs of redness that persists. But in those darker complected individuals, that's where you're going to see what we call dyschromia. So it's going to be more subtle. It's a darkening of the skin tone. So it's really important to have adequate lighting and also feel those areas, because you'll pick up tissue temperature and consistency changes.
Very important. Now, we've talked about changes with the skin and aging a few times, and as I'm getting older, I know I've asked you, how should one take care of one's skin better? So what would you advise older adults to do to take good care of their skin?
Well, great question, because it's never too late to take care of your skin.
Glad to hear that.
Never too late. Some of the tips I give anybody of any age, but particularly older individuals, would be make sure that you are hydrating. You got to drink lots and lots of water. Water is absolutely key. The other thing is keep the skin clean and exfoliate. Now, in an older population, I'd probably use more gentle exfoliants on the skin, but it's really important because that removes a lot of the buildup, a lot of the dead skin cells. It can mitigate wrinkling. There's a lot of nice things that exfoliation can do. The next would be moisturization, but I would use a sunscreen. And even if somebody's not outside, wearing a sunscreen would be really important, because even if they're driving, if they're just walking around outside for 20 minutes, if they're sitting in a patio where they get some sun, we need to protect our skin from UV radiation. That's very, very damaging. And if that's something that they're not comfortable doing, just wearing protective clothing, wearing hats, those types of things, and being really mindful of their environments, because a minor bump or trauma to their skin can induce a pretty significant injury. So our skin does age. It starts aging in our 30s.
And it bruises very quickly
Very
with minor
quickly.
injuries.
But our aging accelerates in our 60s. So, and to that point, the epidermis and dermis get thinner. We lose some of the vascularity, so the susceptibility to minor trauma is pretty high. So skin tears, pressure injuries, the bruising that these individuals often experience is much greater.
What are cost-effective products that older adults can use to moisturize, to exfoliate?
Great question.
And I have a personal interest in this.
Really, I look for anything that has olive oil base or a coconut oil base,
Oh.
because they allow the skin to breathe. You don't need to spend a lot of money on skin products. You really don't. There's great products at Publix, at Target, but look for something that has more natural, organic ingredients. My rule of thumb is if I can't pronounce it, I don't want to put it on my skin, essentially. But use lotions or emollients that don't have alcohol in them, don't have perfumes in them. So using things like CeraVe, Lubriderm, Curel, the nice Niveas, those types of things that have really good moisturization.
Old-fashioned stuff,
Old-fashioned
actually.
stuff, yeah, old-fashioned stuff. And even, you can even just take a tiny bit of olive oil and rub that on your skin. That's fine too. But it's just nice to really protect that skin and give it its moisturization, because we lose the ability, our oil glands don't produce as readily as we get older, so we need to replace that loss.
And what about exfoliation?
Exfoliation, I would use gentle sugar scrubs. They're very gentle. There's a lot of products out there now that have very gentle exfoliations, or very like gloves that can be worn that are very gentle. But again, you want to use things that are gentle, not harsh or caustic, especially with older skin. But really cleaning the skin is important. And I think older individuals need to realize too, hot water, I would not use hot water. I would use warm water. They don't need to shower or bathe every day unless they're really dirty for some reason. 2 or 3 times a week is sufficient, and it'll prevent drying out that skin.
You know, I've never heard anybody say that, but I've always felt that it may not be necessary to shower every day.
It isn't. It strips the body of its oils, of the natural biome that's on there that's protective. And so unless there's a reason, if they become soiled or whatever, then of course that necessitates taking a shower or a bath. But they don't need it every single day. Really don't.
And that sort of goes in line with, many older adults who are in care settings really don't like being showered every day.
No, they don't need to. They really don't need to unless there's a reason. So if there was an incontinence episode or soiling that happened for whatever reason, or, there's reasons why, right? For the most part, they don't need to be bathed or showered every single day. 2 to 3 times a week is sufficient.
And in fact, some people take a couple of showers a day, and, I'm wondering if that's necessary.
That's very drying on the skin. That's very, so, after they get out of the shower, the bathtub, whatever they're doing, pat the skin dry and immediately apply a lotion following that. That's when the
Pat
skin,
it dry, not
pat it dry,
scrub
don't
it
rub,
dry.
don't rub. And make sure you dry between the toes. That's always important too.
That's so important. You've given us such a lot of good information today. Where can our audience find more resources on this topic?
Oh, good question. I would firstly recommend the National Pressure Injury Advisory Panel. You can just put that in your search term and they will pop up. Tremendous resources there. A lot of free downloadable educational materials that you can post around the facility. Lots of valuable resources there. Also, the Agency for Healthcare Research and Quality
Indeed.
is a great resource. Google is a great resource, and recognize too, many hospitals or facilities actually have really good resources internally regarding education. So I think it's important for any facility to establish a baseline of incidence and prevalence. There's literature out there to show you how to do that. So then based off of your numbers, there's implementation strategies that can be done to reduce those numbers. And I think another important thing is to always make sure you have a wound care champion on staff. Somebody that kind of is the point person, and that can really be anybody, that kind of takes the charge of making sure everybody's skin is healthy as much as possible in that facility or in that clinic or wherever the case is going to be. So there's a point person to go to for skin issues or skin concerns.
I wonder if they could be called the skin steward.
Absolutely. You can call them whatever you want. Absolutely.
I mean, that might mean a lot more in some settings
Absolutely. Because
than
that's
a
really
wound
what we
care
are.
nurse.
Correct. It's really being a skin steward. We need to take care of the skin we're in, but the skin that our patients are in as well.
Dr. Barnhart, it's been such a pleasure to talk to you today. We've learned a lot, and thank you so much for joining us and sharing your experience with our audience. Please stay tuned for upcoming topics from our renowned subject matter experts.
Thank you.